Now, the last topic in this symposium is about the guidelines and summary of various management modalities in the medical treatment of REF, that is heart failure with reduced ejection fraction. Dr. Jamshed J Dalal is going to give a talk on this. May I request Dr. Dalal, please?
Thank you very much indeed. I'm going to basically talk, it's more a summary talk because I think most of these subjects have been well described since the talks in the morning. So I'm predominantly going to talk about guidelines which basically just sort of update us on what we have discussed. I would like to first mention that we need to remember now the 2001 update of actually the of heart failure per se, because I think that's important and especially became important with the Emperor Preserve trial. And we know that reduced heart failure less than 40% and mildly reduced, what we used to call the mid-range, has now been called mildly reduced, 41 to 49. Preserved heart function is actually more than 50%. And of course, the important concept of improved heart function where the ejection fraction was low and then following treatment, it improved. If we look at the latest ACC guidelines, actually, I think this particular slide virtually summarizes almost everything. We have 4 important drugs as has been described: ARNI, beta blockers, MRA, and SGLT2. So these all blue boxes are the 4 pillars. We also know that diuretics are required, but they do not produce survival improvement and therefore are required as per need of the patient's volume. All the guidelines say that ARNI is preferred over the use of AC inhibitors or ARBs. Again, all patients, when possible, with eGFR more than 30 should be on an MRA. SGLT2 for patients with GFR more than 30 for DAPA and more than 20 for EMPA. Again, in addition to these 4 major pillars, you can use hydralazine isosorbate nitrate concentration, which is particularly useful when you cannot use these agents, especially because of major issues with kidney function and CKD. And I think in India, we have this combination often used and must not be forgotten. Again, another drug which is not used frequently is ivabradine. And I think it's important because we are not paying that much attention to the resting heart rate, and the control of heart rate in patients with heart failure is extremely important, as we've seen from many trials. And clearly, it's also important that achieving target or maximum tolerated doses is not necessary. So if you don't need to maximize any of these doses before moving on to the next dose, but clearly the addition of SGLT to MRA as soon as possible would be worthwhile. Another point to mention is that AC and ARB should now only be considered in patients who have contraindication, intolerance, or non-availability of ARNI. So clearly all guidelines now suggest that ARNI should be the first drug of choice, and there is no need to give AC inhibitors or ARBs, titrate, and then add ARNI. So clearly, starting ARNI has now been the accepted norm. Amongst the beta blockers, you must remember that there are 3 beta blockers which have been studied, and we should probably restrict ourselves to these 3 beta blockers. Again, if you look at the ACC guidelines, it says direct to ARNI approach. So clinically, initially, directly go to ARNI, no need for using AC or ARB. And in my opinion, of course, shift patients who are on AC or ARB onto ARNI as soon as possible. The ideal time to consider therapy optimization is during the hospitalization of the patients. And it's important to prioritize ongoing titration during the hospital stay. So the important thing is, again, the early use of ARNI and the 4 drugs, because we know that the benefit of these drugs is very early, and therefore we should not wait for them to be discharged and come to follow up for start of treatment. And I think we are all very well aware of trying to start as much as possible all the 4 drugs, even if it requires small doses. And again, as you saw from previous presentations, we need to monitor blood pressure, electrolytes, and renal function quite closely. Just a word on ivabradine. I think we need to remember that heart rate is important. It's also important that we need to adjust the beta blocker dose to maximum to adjust for the heart rate. Often what happens is that the blood pressure tends to drop and we can't push beta blockers, and therefore we need to use ivabradine. Above age of 75, 2.5 twice a day, below 75, 5 milligrams twice a day. Reassess the heart rate, and depending on if the heart rate is less than 50, then reduce the dose. Heart rate between 50 and 60 is ideal. Heart rate more than 60, you may consider increase of the dose. Again, ACCHA guideline also tells to look at other aspects of treatment of heart failure. For example, how to initiate, add, or switch, how to titrate the dose. I think that's very much important when you talk of implementation of guideline treatment. Also, when to refer to specialist centers, coordination, adherence of drugs is very important. And also from that point of view, we need to look at medication cost and availability of drugs, and of course, specific patient cohorts, which may be different, like African Americans, older groups, for example. And again, we know that there is an increasing complexity in treatment management, and therefore we need to apply this with heart failure clinics, etc. We need to look at comorbidities, and of course, don't forget the end-stage heart failure, where palliative treatment is also important. So besides just giving medicines, look at this overall 10 pivotal issues that ACC talks about. Moving now on to ESC 21. Again, if you look at class 1 indication, same AC inhibitors, beta blockers, MRAs, EMPA, DAPA, and of course, ARNI comes as class 1B because of the absence of multiple trials that are available. So clearly, ESC and ACC are quite agreeable on the point. Again, ESC suggests a simplified first-line therapy. That means initiate again sacubitril valsartan rather than AC inhibitor ARB. So I think this now must be a standard of care, that we should straight away go to ARB. If the patient's on AC or ARB, then shift them over to ARNI rather than using any of the other drugs. And again, very important point, do not require to keep checking plasma concentration or NT-proBNP before you initiate ARNI. So we also know that patients with heart failure with preserved ejection fraction, BNP may not always be elevated, so that cannot be used as a decision for treatment. Of course, the push for ARNI is very simple to understand. It was one of the first drugs which came out with the important aspect, not the first, sorry, beta blockers and others were there, but again, one of the newer drugs to came out with improvement in heart failure hospitalization and longer living, and you can see from that. And again, very important to point the very early benefit of the drugs, which is why we need to start these drugs within the hospital rather than in the outpatient department. What are the diagnostic tests that ESC recommends? Again, if you look at the class 1A classification, NT-proBNP, ECG, echo and chest x-ray, and of course, routine blood tests for further evaluation. If we look at further aspects in the ESC guidelines, of course, we've already mentioned the 4 pillars, but we need to go beyond that in terms of certain mechanical devices. And if the LV ejection fraction is less than 35% and QRS is less than 160, if it's non-ischemic, ICD implantation is class 2A. If the patient is ischemic, it's a class 1 indication for ICD implantation. If the patient has ejection fraction of more than 35%, therapy not indicated, device therapy, then of course, consider various other continuous treatment. If the patient's in sinus rhythm, ejection fraction less than 35% and QRS more than 130, then class 2 indication if the QRS is between 130 and 149, and a class 1 indication for a CRT implantation if the QRS is more than 150. Whether you put both ICD and CRT or plain CRT will depend on these factors as well. Again, recommendation in terms of the 4 other commonly available drugs, ivabradine I mentioned already, 2A guideline recommendation, isosorbide dinitrate and hydralazine 2A again, digoxin 2B. I know there's always questions about whether we should use digoxin or not. I think there's clear evidence that digoxin reduces hospitalization, and therefore from that point of view, it can be used. I think it's particularly benefit when the patient cannot tolerate other drugs because of very low blood pressure. I think we need to monitor the levels of digoxin, not to produce digoxin toxicity. And I still think most of us use it when the ejection fraction is very low, patient remains symptomatic, and blood pressure is very low. Vericiguat is a new drug available for patients with heart failure. And again, classification at the moment is class 2B. Again, if we look at some of the changes in the guidelines compared to the previous, the 2021 is a more simplified treatment algorithm. SGLT2 now inhibitors are now become class 1 drugs. And we all mentioned again and again 4 key drugs for the therapy of treatment of heart failure. We should also look at the patient's phenotypes, and I think must tailor the management depending on the patient's phenotype. And I mentioned about the use of ICD and CRT in the selective group of patients. The other thing that they've done is they've changed the definition of mid-range into mildly reduced. So now we call it as heart failure with mildly reduced ejection fraction. And I think it's an important group. And we all believe that this is probably more similar to the heart failure with reduced ejection fraction. And I think if somebody asks how we should treat these patients with MR ejection fraction, I think it should be the same way as heart failure with reduced ejection fraction. And for diagnosis of heart failure with middle range ejection fraction, elevated BNP, plus other evidence of structural, more likely may or may not be there. And it's important, therefore, to look at the ejection fraction as well. There's various table of recommendations for the management of these patients. And again, ESC has come out with a lot of steps in both for diagnosis and for management of heart failure with preserved ejection fraction. And this is a topic by itself. How do you diagnose and how do you manage ejection fraction with a preserved ejection fraction? Again, one of the new things is the importance of monitoring for anemia in all patients by monitoring serum ferritin saturations, the class 1 indication. Of course, intravenous ferric carboxymaltose use 2A classification. Do not use erythropoietin stimulating agents, which we often used in the PRAS, class 3 indication. If you look at the use of cardiac MRI, it's a class 1C recommendation. It's important in patients with infiltrative disease, myocarditis, sarcoidosis, amyloidosis. I think so it's important. It has a role to play and should be used selectively as well. And this is more important when you come with the TTR type of amyloid. Now, Pfizer has come out with the drug tafamidis, which is a treatment for the group of drugs, and therefore that has now been given class 1 indication. Of course, better than MRI, of course, is the pyrophosphate nuclear scanning, which can diagnose patients with TTR, which is a rare form of amyloidosis seen in younger age group and quite severe in its intensity and morbidity. And with therapy available now, the investigation and looking for this is important. Again, another recommendation about patients with heart failure and cancer, because we know that cardiotoxicity of malignancy, anti-malignancy drugs is a big problem. So we need to evaluate these patients. They should all have a CV assessment. And therefore, there is some data now, of course, coming in of the prophylactic use of all these 4 drugs, which we use for treatment heart failure, may be beneficial in terms of actually preventing these patients. That's a debatable point, and the class is about 2A. But certainly patients with cancer undergoing treatment should be evaluated thoroughly before and after treatment with the possible use of drugs to prevent them from going into heart failure. As far as heart failure and atrial fibrillation is concerned, there are 2 major differences between the 16 guidelines and the 21 guidelines. DOACs, NOACs have been a class 1 indication from an earlier class 2A. And again, the use of beta blockers in AF, we know that is not so useful, and it has been dropped from a class 1 to a class 2A indication. So some changes in terms of AF and heart failure. Again, important, we don't, of course, use this not frequently because of cost issues, but left ventricular assist devices should be considered in patients with persistent severe symptoms, despite optimal medical and device therapy without severe right heart failure in the absence of any major contraindication. So these would be the guidelines: less than 25% EF, more than 3 hospitalization for progressive worsening of end organ damage. And I think in the next session, we are going to have some talk on devices and heart transplant, etc. And again, when you look at the phenotypic approach of management of heart failure, the side again covers everything. There are 2 aspects where all patients will benefit. There are 4 drugs. They must be given to all patients, and all patients must be given exercise rehabilitation and professional disease management. So these 2, exercise rehabilitation and your 4 pillars, are for all patients. Diuretics depend on volume overload, and this I've already covered: use of CRT, ICD, when to anticoagulate, atrial fibrillation, use of digoxin. And of course, I think this has also been discovered, the role of intervention and bypass surgery. Important, of course, iron deficiency should be covered. Mitral valve repair in those with LV dysfunction, with severe mitral regurgitation. Very important, heart rate control. Certain group of patients who may require hydralazine isosorbide, and of course then transplant and mechanical devices. A brief word on heart failure with midriff ejection, with mildly reduced ejection fraction. Again, all these drugs now are forming the class 2B. So there's not enough data to put them anywhere near class 1. So your 4 pillars remain there, but do not come into class 1 treatment. But again, screening is very important. So most important in heart failure with middle range, mildly reduced, or with preserved ejection fraction, you need to look at the phenotypes and the etiology which needs to be treated. Thank you. So recommendation for treating patients, screening. This is with heart failure with preserved ejection fraction, very important. You need to screen the patients and treat the comorbidities. That has clearly been discussed. Yes, there is some data in Paragon heart failure trial that some of these patients may benefit, especially in the mildly reduced rather than in the completely normal. And again, Emperor Reserved has opened up this whole Pandora's box of treating ejection fractions from very low levels to almost normal. And therefore, finally, in prevention of chronic disease, you must look at other factors. treatment of hypertension to prevent heart failure, because hypertension remains one of the very important factors, class 1 level, to check for that. Treatment recommendations, patients with high CV risk need to be evaluated and treated. Early use of SGLT2, and again, extremely important, counseling for sedentary habits, obesity, cigarette smoking. So all these things also should be required, not simply the drug therapy when you talk of management. When you talk of non-invasive telemetry at home, class 2B indication, use of all the pulmonary artery pressure monitoring, etc., again, class 2B indication. So yes, these are important, but may not be so important in our day-to-day practice. Further, if because we got lots of papers, even from India, CSI position paper, the Heart Failure Association papers, and I think we can all look at those for further information as well. So thank you very much indeed for listening to me.